Hello, my name is Jillian Hanlock, and for my genetics presentation, I am doing it on polycystic kidney disease. I decided to do my presentation on polycystic kidney disease because I used to work as a dialysis technician. Some of my patients were diagnosed with polycystic kidney disease, which eventually led them to have kidney failure. One patient in particular was a middle-aged male who had two daughters, and one of them was diagnosed with polycystic kidney disease. He felt very guilty about it because he knew that it was a genetic disease and he felt that he was the one that gave it to her. And I know he was very emotional about it because he knew what she had coming in the future if her kidneys failed as his did. So this got me interested in the genetics of polycystic kidney disease, and I will go into that in the next couple slides. So what is polycystic kidney disease? According to the Genetic Home Reference, it is a genetic disorder that causes clusters of fluid-filled sacs called cysts develop in the kidneys and interfere with their ability to filter waste products from the blood. The growth of the cysts cause the kidneys to become enlarged and can lead to kidney failure. One thing that is interesting about this disease is that it develops in both kidneys. So that is why some people will end up with kidney failure because, as we know, you only need one kidney that functions well. But in this case, both kidneys are affected. I like this photo because the average size of a human kidney is a fist size, but a kidney with polycystic kidney disease can get as large as a football and can weigh up to 30 pounds. The following are complications of polycystic kidney disease. The first is dangerously high blood pressure. Most patients with polycystic kidney disease have high blood pressure, and this is due to kidney ischemia. The blood flow to the kidneys decreases as the vessels are compressed due to the cysts and enlargement of the kidneys. The control of hypertension is a priority in these patients because uncontrolled hypertension can eventually lead to kidney failure. Another complication is pain in the back or sides, and this is due to the placement of the kidneys inside the body. Another complication is blood in the urine, recurrent urinary tract infections, kidney stones, and the kidney stones is common, but this is for an unknown reason. Another complication is heart valve abnormalities. A common one is mitral valve prolapse, uh, left ventricle hypertrophy, kidney failure, and patients with this disease can also develop cysts in their liver and their blood vessels. There are two major forms of PKD. The first is autosomal dominant form, and this is the most common. Signs and symptoms begin in adulthood, but kidney cysts are typically present at birth or childhood. So this is an inherited disease. Autosomal dominant means that if one parent has the gene, then the children will have a 50% chance of developing PKD. It does not skip generations like some other genetic diseases. So this is what the patient that I was talking about in the beginning, he has the autosomal dominant form. So I made a pedigree over here, and this shows him and his wife. He has the gene, and then his wife doesn't. And together they had two daughters. One daughter has the gene, and the other daughter doesn't. And so if they were to marry people who didn't have the gene, only the daughter who had the gene would have a children would have a 50% chance of developing the disorder. So 100% of patients will who have the gene will get kidney cysts by the age of 30. So the second major form of PKD is the autosomal recessive form. And this is a much rarer form, and it's often lethal in early life. The signs and symptoms of these are usually apparent at birth. So according to the PKD Foundation, 1 in 20,000 children are affected with this disease. They normally die in early childhood, and as you can see in the photo, both parents have to carry the gene, but they don't have the disease, and only 25% of their children will develop the disease. So it makes it much harder or much rarer for the children to get the disease. So who is affected by PKD? PKD affects 500,000 people in the United States. The autosomal dominant affects 1 in 500 people, but the autosomal recessive affects 1 in 20,000 people. So that just shows how much more common the autosomal dominant is compared to the autosomal recessive. The following are some tools that are used to diagnose PKD. So the ultrasound is used as the initial screening. The definitive diagnosis is an MRI. The CT scan can be used to assess the kidney's perfusion. And with the MRI, a finding of 5 or more kidney cysts is what is classified for the diagnosis of PKD. So the urine analysis can show proteinuria and will indicate a decline in kidney function and impaired elimination. There could be hematuria, bacteria in the urine, and the BUN levels will be elevated, and the creatine clearance will be elevated, and a low GFR. Genetic testing is not usually used unless a patient has a family history and is having atypical imaging findings. So when assessing a patient who is suspected to have PKD, you want to start by taking the patient history. Especially the family history is important with people suspected of having PKD because it is a genetic disease. And next, you're going to want to perform an assessment, ask about pain, abdominal discomfort, constipation, changes in urine color and frequency, hypertension, assess the abdomen. A distended abdomen is a sign. And nocturia is an early symptom because the decreased urine concentration ability. And then you're going to want to palpitate bilaterally for flank masses. Polycystic kidneys are easily felt due to their size. Monitor renal function. There's normally a reduction in the GFR. Urine elimination, uremic symptoms, including anorexia, nausea, vomiting, pruritus, and fatigue. You're going to want to monitor the hydration and fluid and electrolyte balance. These patients normally retain water and sodium, and that can lead to hypertension and edema. When assessing a patient who is suspected to have PKD, you want to start with the patient's history And it's important to focus on the family history since it is a genetic disorder to find out if one of the parents have PKD. And then perform an assessment. You're going to want to ask about pain, abdominal discomfort, constipation, changes in urine color and frequency, hypertension. Assess the abdomen. A distended abdomen is a common sign. Nocturia is an early symptom as well, and this is due to decreased urine concentration ability. And vital signs is important, especially high blood pressure. Palpitate bilaterally for flank masses. Polycystic kidneys are easily felt due to their size. Monitor renal function. There's normally a reduction in GFR. Urine elimination, uremic symptoms, anorexia, nausea, vomiting, pruritus, and fatigue. Monitor hydration and fluid and electrolyte balance. Person with PKD has retained water and sodium, and this leads to hypertension and edema. When caring for a patient with PKD, you're going to want to make sure to give them their hypertension medicine and their pain medication. You're going to want to provide fluids and foods based on the patient's condition. Encourage increased fluids if the patient has a urinary tract infection, which is common, and restrict fluids if the patient has renal failure. Obtain specimens for urine analysis and culture sensitivity as ordered to evaluate for hematuria, proteinuria, and infection. Obtain specimens for laboratory tests for electrolyte levels, and allow the patient to verbalize their feelings and concerns, especially related to the progression of their disease, and especially if they're heading towards renal failure, they're going to need some support and guidance. If the patient already has renal failure, then you're going to want to prepare them for dialysis or whatever renal replacement therapy they have. Encourage genetic counseling if the patient is planning on having children, and refer to social services as well. Early infection management is key for PKD patients because it can prevent or reduce complications that could lead to further kidney injury. So some symptoms to watch for infection: monitor for fever, abdominal pain, and either leukocytes or serum markers of inflammation. You're going to want to take blood and urine cultures. Antibiotics will be prescribed if there's an infection, and if antibiotics are prescribed, you're going to want to monitor serum creatine levels because some antibiotics are nephrotoxic. And sometimes they'll also do percutaneous or surgical drainage of the cysts to help with the infection and the pain. So for health promotion, there's no way to prevent PKD except through genetic counseling or just not having children if you have the disease. Medications are currently being developed, and these are hoping to interrupt the pathways that promote malignant cyst formation, such as molecular signaling for cell division or endothelial growth. But right now, the best way for a person who has the disease who has the gene is early detection and management of hypertension. This will slow the progression of kidney damage and impaired elimination. I wanted to give you guys a little background on why managing hypertension is so important for someone with PKD. And this is because high blood pressure develops early in the course of the disease and is caused by the activation of the renin-angiotensin aldosterone system and other significant pathogenic mechanisms. Hypertension is a major contributing factor for the increased cardiovascular morbidity and the mortality in patients with PKD. Arterial hypertension occurs much earlier in patients with PKD than in the general population. The median age of diagnosis is 32 years for men and 34 years for women. Healthcare professionals aim for the blood pressure of a PKD patient to be 130 over 80. They advise to limit the intake of salt and caffeine, to have regular exercise, and to stop smoking. They also will prescribe a hypertensive medication and a thiazide diuretic. But currently, there is no evidence that shows if a certain type of hypertensive medication works better than the other. But all these interventions hope to manage the patient's hypertension. Pain management is also important for these patients. Patients with PKD report pain located in the lower back, the abdomen, head, chest, and legs. Management of this pain includes transcutaneous electrical nerve stimulation, and this can be helpful in managing renal colic. Non-analgesics, including acetaminophen, and this is the first line for pain medication. Next would be opioid agents, and that is the next step if the pain is not adequately controlled. But there are adverse side effects with opioids. The next is tramadol. Gabapentin can be used in the treatment of genitourinary pain. Spinal cord stimulation, acupuncture can help with the low back pain. Kidney cyst aspiration, it only normally relieves the pain in a short time period, and it's at about 18 months. And current research is being done on other surgical measures for these patients. PKD occurs in all races, but the differences between races haven't been studied well. So I chose to do my culture on African Americans. African Americans had a slightly higher onset of end-stage renal failure than whites. They got it at age 43.2 versus 55.4. African Americans with PKD and sickle cell trait reached end-stage renal failure earlier than African Americans with just PKD alone. African Americans are almost 4 times more likely as whites to develop kidney failure. So this would be important when caring for someone with PKD you want to assess them for renal failure because they're more likely. They also have high blood pressure in 68% of the PKD patients, and other renal manifestations were flank pain, hematuria, and proteinuria. Those were the most common. Early ultrasound detection and strategies to preserve renal function should be offered to at-risk individuals to improve outcomes. And more studies are needed to define the effect of race and ethnicity on PKD progression. So that's the end of my presentation. There's a lot of great information out there on PKD if you're still interested in more. There's a polycystic kidney disease foundation, and they offer walks and many different resources. So check it out if you're interested. Thank you again for listening to my presentation.